In this episode, we are going to discuss the acyanotic congenital heart diseases, including atrial septal defect, ventricular septal defect, patent ductus arteriosus, and endocardial cushion defect. Beginning with ASD, the first question is, what are the risk factors of atrial septal defect? The risk factors include Holt-Oram syndrome, fetal alcohol syndrome, and Down syndrome. What is Holt-Oram syndrome? You can remember Holt-Oram by the acronym ASD. It includes ASD, that's atrial septal defect. S stands for slow heart, usually the first degree heart block, and D is for deformed bone, such as absent radius and especially carpal bone and other upper extremity bone deformities. Vignette: a neonate born to an alcoholic mother who did not abstain during the pregnancy. The infant has microcephaly. What other findings in auscultation and facial features you expect in this infant? Regarding the facial features of fetal alcohol syndrome, we should remember thin vermilion and small philtrum, as well as a small palpebral fissure. In terms of cardiac auscultatory findings, we can hear the findings associated with ASD that we will discuss in a second. Now, what are the four different types of ASD? One is the normal physiologic variant, and that is patent foramen ovale. The other is primum type ASD, the other is secundum type ASD, and the other is sinus venosus ASD. What is the clinical relevance of knowing these types is that usually the secundum type is the most common type, and it's usually an isolated defect, while the primum type ASD is not isolated and usually is associated with atrioventricular or endocardial cushion defects. So just very briefly on the pathophysiology, imagine this is the septum primum to the left of septum secundum. This septum primum goes up, but usually does not reach all the way up to the atrial free wall. And usually there is also a foramen primum in this septum primum. That foramen primum usually closes. That foramen also is on the region of endocardial cushion, and so that's logical to know that if it fails to close, we will have primum type ASD, the very rare type that's also given the anatomical proximity is associated with endocardial cushion defect. Now, this septum primum continues to grow, but normally never reaches the top wall of the atrial cavity. Therefore, there is always a foramen secundum that exists between the free edge of the septum primum. However, when the septum secundum grows, that closes that foramen secundum. However, if this septum secundum failed to completely grow and reach the top wall, the foramen secundum will remain open. And so we say the common cause of secundum type ASD, even though foramen secundum is formed within the septum primum, is the failure of growth of the septum secundum. Please remember this. Now, what's the normal physiologic type? Well, imagine the left side, which is the septum primum, is to be pressed upon an opening on the septum secundum. That opening on septum secundum is called fossa ovalis, or oval window. So imagine this flaps to it and closes it, right? There is nothing going there. But if the pressure in the right side increases, the pressure can push the septum primum on the left side away, and now blood can move from this limbus of fossa ovalis towards the foramen ovale to the left atrium. This is a right to left shunt that causes what significant clinical condition? It can cause paradoxical emboli. That is, the venous emboli that are on the right side of circulation get access to the arterial system and left side of the heart, for example, causing embolic stroke. And the final subtype, and that is the sinus venosus ASD, and that's just simply malpositioning of the SVC insertion site near the atrial septum. Again, please remember that any type of ASD can allow movement of blood from any direction, but commonly because the left side of the chambers have higher pressure, it's a left to right shunt. But if chamber pressure reverses, ASD similar to PFO can allow a right to left shunt. Okay, enough pathophysiology. So what are the clinical findings of ASD? I would like you to know that all ASDs are associated with the well-known wide fixed splitted S2. However, depending on whether or not we have an early or a late ASD, we may have different types of murmur. Usually the early ASD is just associated with systolic ejection murmur on the pulmonic area due to increased pressure over the pulmonic valve, and you know the pulmonic area is the upper left sternal border. And if you are asked what is the possible second component of the systolic murmur of ASD, if any murmur is present, that will be that of increased flow across the tricuspid valve, and that's defined as the diastolic rumble in tricuspid area because again of increased flow between the right side of chambers. Now, if you are asked what is the murmur specifically heard on the late ASD, that will be the murmur of the complication, which is pulmonary regurgitation. After a while that pulmonary has increased flow across its valve, it will start to be insufficient and regurgitate. And where do we hear the pulmonic regurgitation? Similar to aortic regurgitation, pulmonic regurgitation is heard at the Erb's point, which is the mid-left sternal border. Don't confuse it with the tricuspid region, which is lower left sternal border. Just to bridge to semiology, do you remember the other murmurs you can hear on the Erb's point versus lower left sternal border? In addition to the regurgitant murmurs of semilunar valves, aortic and pulmonar, we can hear hypertrophic cardiomyopathy, the systolic murmur of HCMP at the Erb point, and that's why I call it the Erb with H, Erb point. What about the other murmur we can hear on the lower left sternal border? Well, in addition to being the region for tricuspid valve and therefore tricuspid stenosis or regurgitation being heard in that area, we hear the holosystolic murmur of ventricular septal defect in that lower left sternal border. Now, remember that many of the ASDs are usually asymptomatic, especially if they are small. Now, if you're asked what are the other clinical symptoms other than the auscultatory findings, remember the common findings in these left to right shunts, the septal defects, ASD and VSD, include recurrent respiratory infections, failure to thrive, and fatigue. Now, what's the common workup of almost all congenital heart diseases? Chest X-ray, ECG, and echo. So what are the chest X-ray findings in ASD? Logically, we have increased pulmonary vasculature and possibility of increased size of the heart. What are the ECG findings? We have findings associated with right atrial enlargement and right ventricular hypertrophy. Right ventricular hypertrophy specifically may show right axis deviation. Another ECG finding is PR prolongation. Don't confuse it with what we have in first degree AV block. In other words, PR interval is longer than 3 to 5 small square. You remember what was the method of detecting right axis deviation? The overall QRS complex is positive in 2 and AVF, but it's overall negative in lead 1. Do you remember the criteria for right ventricular hypertrophy? We have kind of the reversal of the R progression in precordial read. In other words, we have an R wave that's larger than 7 millimeters in V1, or the ratio of R to S in V1 is greater than 1. What is the oxygen saturation or oxygen partial pressure in the right side of chambers? Its value is higher than normal levels expected in right-sided chambers or pulmonary artery. or it's just described as an upscaling of the PaO2 from SVC-IVC to right atrium. What is the general management of ASD? It's usually closes spontaneously. However, if the patient has symptoms that fail medical management, or is a patient younger than 1 year of age with pulmonary hypertension, or any child with larger defect that has failed to close over time, the surgical management is the recommendation. Again, remember these indications for surgery: the symptomatic patient who has failed the medical management, presence of pulmonary hypertension in a kid younger than 1 age, and the septal defect that has failed to close, especially in symptomatic kids. This is the same rule for management of other septal defect, that is ventricular septal defect. Okay, moving on to our other septal defect, the other acyanotic CHD, and that's ventricular septal defect. Now, regarding ventricular septal defect, you may of course know condition is again associated with increased flow in the pulmonary circuit. The tricky point is you may be asked a question about left versus right ventricular end diastolic volume. Now, while we have a flow during the systole from the left ventricle to the right ventricle through the septal defect, increased flow in the pulmonary circuit means increased venous return to the left side of the heart, and therefore we have increased left, not right, but left ventricular venous return, which is manifested as increased left ventricular end diastolic volume. Understanding of the pathophysiology and clinical features requires understanding of this fact. Again, as you can see, I have mentioned in the pathophysiology here that we have a volume overload in right ventricle that will translate into volume overload in the left-sided heart after the left side venous return is increased. Also remember that the initial manifestation of volume overload is dilation, and then later on is the hypertrophy. Now, an important point regarding pathophysiology is why VSD, regardless of the size, is usually asymptomatic in utero. It's because in utero, the pulmonary system is a high-resistant, low-flow system that prevents any shunting from the left side of the heart. Put it simpler, in utero, right and left ventricular pressures are equal. What is the postnatal transition? By the very first breathing, as well as delivery of the placenta, which is the source of prostaglandins, two factors that keep ductus arteriosus open are removed. One is hypoxia and the other is the prostaglandins. This means closure of the ductus arteriosus. Also, breathing causes dropped resistance in the pulmonary circulation, and all these factors causes a gradient formation that is higher pressure in the left chambers, with resultant left to right shunting through VSD. Now, what are the clinical findings in early versus late VSD? That's the findings in infancy versus the findings in late childhood if it is left uncorrected. In the infancy, the right ventricular volume overload may result in right ventricular dilation. We have increased flow in the pulmonary circuit, and as I mentioned, we have increased venous return to the left side of the heart. In the late childhood, however, because of increased flow in the pulmonary circuit, there will be arterial vascular thickening, resulting in increased resistance in the pulmonary circuit, and this will probably stop the shunt for a while or causes its reversal, and then we will have this right to left shunting, which is formation of a cyanotic defect as a complication of these septal defects, which is referred to as Eisenmenger. Based on what we have discussed so far, under what circumstances VSD can be silent, in other words, we may not hear its murmur. In the first week of life, where the pulmonary vascular resistance is still high and the complete transition to normal circulation has not occurred. Also, when the VSD is so large that there is no pressure gradient and there's been complete total equalization of pressure across the septal defect. Always remember that a factor contributing to the loudness of a murmur is the presence of pressure gradient. If the septal defect is so large that there is no pressure gradient and it has eliminated any difference of the pressure between left and right ventricle, we will not hear it. The third possibility is on that advanced stage when it is transitioning from a left to right shunt to a right to left shunt, and again we have increased pressure in the pulmonary circuit. That equalization of pressure, not because of the larger defect but because of the changes in the pulmonary circuit, will happen, and again we may fail to hear or just be exposed to the silencing of the murmur. By the way, do you remember the timing and location of the VSD's murmur? Well, it's a holosystolic murmur, and as we mentioned earlier, it is on the same area of the tricuspid, and that is the lower left sternal border. Always remember two important differentials of the holosystolic murmur on the lower left sternal border, and one is VSD and the other is tricuspid regurgitation. The tricuspid one, as a right-sided one, would increase with inspiration. Based on what we discussed, which one will have harsher murmur or louder murmur? Small or large VSD? Small VSD, because the pressure gradient is higher. Now, another means of differentiating the holosystolic murmur of the lower left sternal border, in addition to the inspiratory bedside maneuver that changes the right-sided murmur, such as that of tricuspid regurgitation, is to remember that the holosystolic murmur of the ventricular septal defect is defined as a harsh holosystolic murmur. Remember, we mentioned we have also a mid-diastolic rumble in ASD. Now, can you compare and contrast the mid-diastolic rumble of ASD versus that of VSD? Mid-diastolic rumble of ASD is heard on the tricuspid region because of increased diastolic flow across the tricuspid valve. Because after all, ASD is a condition with increased flow from the right atrium to right ventricle. Yeah, so tricuspid should be involved. But in VSD, the mid-diastolic rumble is due to increased flow from the left atrium to left ventricle. In other words, it's a mitral area's mid-diastolic rumble, also defined as apical mid-diastolic rumble, and that once more signifies why I mentioned we have increased venous return to the left side of the heart. We have increased flow in the left side of the heart, even with the possibility of left atrial or left ventricular dilation and fluid overload. We discussed the symptoms of septal defects, including recurrent respiratory infections, failure to thrive, fatigue. What additional symptoms possible, especially in large VSDs? Congestive heart failure. Pay attention to the fact that we are talking about the clinical symptoms, not a sign, because the smaller ones could be associated with louder murmur. Now, we discussed apert, fetal alcohol syndrome, and trisomy, any trisomy, as well as torches, as the possible risk factors associated with VSD. Remember, Down and fetal alcohol syndrome are also common with the risk factors of ASD. Now, how to remember apert syndrome or apert syndrome? Here, for VSD, the VSD as acronym could be helpful for memorizing apert or apert. V stands for VSD, S stands for skull anomalies, and D stands for digital fusion. Remember, Hortolam association with ASD was memorized by ASD. That is one ASD, letter S for the slow heart rate or first degree block, and D for deformities in the bone, absence of radius, and carpal bone deformities. Once more, never forget possible association with torches, cri du chat, and any trisomies being associated with VSD, not just Down syndrome. Again, the murmur is harsh holosystolic at left lower sternal border. We could have loud P2, especially large mid-diastolic apical rumble. Earlier on versus later on, what are the chamber size changes? First changes could be those associated with right ventricular dilation or left chamber enlargements afterwards, but the latest changes are those associated with right chamber, that is right ventricular hypertrophy. Always remember, hypertrophy takes longer time than dilation. What's the similarity in chest x-ray finding between septal defects? In both, we have increased pulmonary markings logically. What the catheters will show, while in ASD, we have just increased oxygenation in the right-sided chambers. In VSD, the catheter pressure assessment of partial pressure of oxygen will show a step up of oxygen saturation from right atrium to right ventricle logically. Remember some ECG criteria for left ventricular hypertrophy. We may have long R in V5 or V6, or we may have long S in V1, or the Sokolov-Lyon criteria that says the S in V1 plus R in V5 or V6 is larger than 35 millimeter in amplitude. Describe the management of ventricular septal defect. We mentioned the majority will close or will be asymptomatic. Regardless, all kids require not only initial echo but follow-up echoes, and that will be the only thing needed for asymptomatic kids. However, for mildly symptomatic kids, we may consider addition of diuretics. If the patient has moderate symptoms added, such as failure to thrive, we should consider nutritional support. And if the patient has severe symptoms, treatment failure, respiratory distress, pulmonary hypertension, early surgical repair is the management. Moving on to the next left-right shunt, PDA, patent ductus arteriosus. If you are asked which one of these shunts are considered normal in preterm infants, that is patent ductus arteriosus. Again, I would like you to remember that all of these left to right shunts are associated with increased volume, with a volume overload condition to the left-sided chambers, and then later on it could also result in increased pressure indices in the right-sided chamber. So if you are asked what side of the heart is prone to eccentric versus concentric hypertrophy, you know that eccentric hypertrophy is due to volume overload. Therefore, all these conditions, the three-letter disorders, are associated with volume overload and eccentric hypertrophy for the left-sided chamber, that's left ventricular eccentric hypertrophy, while the right-sided chamber in the Eisenmenger phase will be associated with concentric hypertrophy because of increased pressure, because of the pressure overload. What are the risk factors of patent ductus arteriosus? Again, the strong association with prematurity means the same risk factors of prematurity. For example, congenital rubella, what you expect to see in the symptoms, the same symptoms that we mentioned for the septal defects, such as failure to thrive and recurrent respiratory infections. Now, what is the murmur if present? The murmur of PDA is defined as machine-like murmur with the diastolic phase being louder. What are the other findings? Could have loud S2 as usual with the conditions with increased flow in the pulmonary circuit, because the loudness of S2 depends on the status of the pulmonic valves when they want to close, and in the conditions with increased flow they are wide open, and then when they close it will be producing a louder closure voice. If you are asked what is the location to listen to the machine-like murmur of PDA, where is it? It is the second left intercostal space. That's exactly the same area that we listen to pulmonic ejection murmur. The alternative site is second subclavicular region. Now, what is the pulse pressure change that we expect to see in PDA? Well, think of PDA as a condition in which part of the aortic blood is kind of shunted out or regurgitated out somewhere that it should not go, like aortic regurgitation, right? In aortic regurgitation, because of dropped diastolic pressure in the aorta, we have widening of pulse pressure. Here, because part of the blood is stolen into the pulmonary circuit, we have dropped diastolic pressure. Both of these means widening of pulse pressure. Please remember that in patent ductus arteriosus. Also remember that similar to aortic regurgitation, presence of widened pulse pressure may also mean possibility of bounding pulse. What findings do you expect in chest x-ray and ECG and echo of PDA? Again, increased venous return and volume overload to the left side would mean possibility of left ventricular dilation initially and left atrial enlargement, plus increased pulmonary markings because of increased flow in the pulmonary circuit. Now, an adjunct test, which is Doppler study, may also show this flow from aorta into the pulmonary artery. Now, there are three important decision point questions when it comes to the management of PDA. What are those considerations? 1, if we are dealing with term or preterm infant. 2, if there is any contraindications to medical management or any type of management. And 3, if surgery is directly indicated. Based on this, what is our general approach? Well, generally speaking, the first or best initial treatment is some form of NSAID, preferably endomethacin. But don't blindly answer that question, is the NSAID as management if the patient has contraindications. And now we are talking about two groups of contraindications for medical management. One is contraindication to management at all, and 2, contraindications to medical management. Now, what are the situations in which we do not want to close a PDA? Simply think of it as very good or very bad conditions. And by that I mean when PDA is small or asymptomatic, or if there is no audible murmurs, usually no treatments are needed, as most of them will resolve or will be considered of minimal significance. Second is when either the hemodynamic or oxygenation of the neonate depends on the patency of the PDA due to presence of some form of secondary cyanotic congenital heart diseases. Remember, almost all of the cyanotic congenital heart diseases are dependent on some form of left to right shunt for either oxygenation or for maintenance of the perfusion and cardiac output. Otherwise, the neonate would go to shock. Perhaps the only exception is truncus arteriosus. Now, PDA is not the only type of these left-right shunts. It could be other life-saving shunts such as an ASD, VSD. But if a PDA is present in any of the cyanotic congenital heart diseases, we do not want to close it before we have addressed the life-threatening aspect of that cyanotic congenital heart disease. And in those situations, of course, we give the patient prostaglandin E to prevent its closure. So this is the first set of contraindications to closure at all, or any attempt or intervention for closure of PDA. The second contraindications are those contraindications to NSAIDs. Now, what are the contraindications to indomethacin or NSAID for closure of PDA? Those include, of course, bleeding enthesis or bleeding disorders, but specifically what group of patients and what conditions are we dealing with? Well, remember I mentioned that prematurity is the #1 risk factor of PDA, right? Also remember some of the complications of prematurity are associated with bleeding, right? Do you remember some of them? Yes, intraventricular hemorrhage and necrotizing enterocolitis, among others. Also add active bleeding of any type to this, and you have the list of complete contraindications among a premature neonate to use of NSAIDs. Another contraindication to use of NSAID is, as I said, when we do not want to treat at all, and that is either asymptomatic or a neonate with PDA-dependent cyanotic congenital heart disease. The final contraindication, or better to say, no preference for medical management with indomethacin, is the term infant with symptomatic PDA, specifically if PDA has failed to close after 6 to 8 months, it means at this point in the medicine alone would not be of much use. We need surgical management. Now, finally, of course, whenever in medicine medical management fails, if we have a surgical option, that will be other indication for surgical management. Again, contraindications to treatment, contraindications to medical management, term or older than 6 to 8 months infants, and failure to medical management, all are contraindications to medical management and some considerations for surgical management. What is the preferred surgical method? As you can see here, I have said percutaneous occlusion is preferred over surgical ligation. Okay. Based on what we discussed, I would like to ask you a question. Do patients with Eisenmenger have any indication or contraindication for closing their PDA? Well, remember, Eisenmenger phase is that reversal of left to right shunt, and if by the time Eisenmenger is developed PDA has not closed, that would not be the right time anymore to close the PDA, because patients with Eisenmenger have this pulmonary hypertension. It's a type of right to left shunt, and they may need PDA to maintain cardiac output. One of the important questions in regard to this acyanotic congenital heart diseases is the need for prophylactic antibiotic treatment before procedures. How do we address this issue or question? Remember, for septal defects, we usually do not consider prophylactic antibiotic before any procedure. But in the case of patent ductus arteriosus, two groups of patients would need antibiotic prophylaxis. Who are they? One group are those with accompanying cyanotic congenital heart disease, and the second group, or those who have received surgical management for the closure of their PDA. They require up to 6 months of antibiotic prophylaxis after their percutaneous occlusion. Now, do you remember what is the prostaglandin of choice in the cases that we want to keep the patency of the Ductus arteriosus? Prostaglandin E2, any preparation of PGE2. Okay, moving to our next and final acyanotic or left to right shunt, which is kind of a combination of several of these defects we discussed, and that is endocardial cushion defect. What is exactly the endocardial cushion defect? ECD is an atrioventricular canal defect with ostium primum type ASD, as we already alluded to, a VSD plus a single atrioventricular valve. These are the common associations that form endocardial cushion defect. Now, if you ask what's the most common congenital heart disease among the patients with trisomy 21, even though we mentioned VSD and ASD, always remember ECD, endocardial cushion defect, is the most common one. Now, why I said this endocardial cushion defect is somehow in between acyanotic and cyanotic lesions is because of the fact that the neonates could have early cyanosis, specifically peripheral or acrocyanosis, even though theoretically it is still a left to right shunt. What is the clinical hallmark of ECD? The early manifestation is early congestive heart failure. What's the pathophysiology of these findings? Well, acrocyanosis and lip cyanosis or mucocutaneous cyanosis is because of poor oxygenation due to mixing of the bloods, deoxygenated and oxygenated. But presence of a single atrioventricular valve indicates the possibility of regurgitation, and that would result in early heart failure. So what would be the symptomatic presentations? We will have a patient, a newborn, with diaphoresis, dyspnea, and crackles mostly around 6 weeks after birth. That is, the regurgitation is so severe that it just takes 6 weeks to cause heart failure. What auscultation you expect to hear in patients with ECD? Well, not because of single or common atrioventricular valve, but because of increased flow down the pulmonic artery, pulmonary system. We have delayed closure of pulmonary artery, and therefore we will have again fixed splitting of S2. Remember the other condition that has this finding? Yes, ASD. The other auscultatory finding is presence of systolic ejection murmur, again not because of increased flow down the aortic area, but again remember we are talking about these being theoretically a left-to-right shunt, and therefore we will have increased flow down the pulmonary circuit, and that is why we will have this systolic ejection murmur on the pulmonic side. What's the other auscultatory finding? Well, we mentioned that we have VSD, right, as part of the complete AV septal defect, CAVSD. Because of that, we will have the holosystolic murmur of VSD at the lower left sternal border. And what else? Well, finally, we also mentioned that we have this huge regurgitation, so we expect to hear the regurgitant holosystolic murmur in the mitral area. So if you are asked what congenital heart disease could be associated with holosystolic murmur in both mitral and tricuspid region, remember that it's a condition in which both atrioventricular valves are regurgitant. The only example is endocardial cushion defect. We will have apical holosystolic murmur because of mitral regurgitation. We will have lower left sternal border holosystolic murmur for two reasons. One is because that is the location of tricuspid regurgitation as well, but also because in that same region we can hear the holosystolic murmur of VSD. Now, a very important gotcha question here. True or false? Endocardial cushion defect is because of a single heart outflow tract. That's false. Presence of a common atrioventricular valve is what defines the pathogenesis of endocardial cushion defect. Presence of a common outflow tract out of the heart is a cyanotic heart disease called truncus arteriosus. We will talk about it later. So, quickly reviewing the acyanotic congenital heart diseases, we have a neonate with murmur but no central cyanosis. Usually some sort of risk factor is also present. What are the common possible findings? We may have failure to thrive, repeated respiratory infections, or fatigue, or even symptoms of heart failure. If this neonate has Holter-M or Down or fetal alcohol syndrome, wide or fixed split S2, systolic ejection murmur, and diastolic rumble of tricuspid regurgitation, we are dealing with ASD. We use surgical management only if the patient is symptomatic and the valve is not closing. We remember that one type of ASD, which is ostium primum ASD, is associated with endocardial cushion defect, and we will have the regurgitant murmur of both atrioventricular valves in their regions and possible symptoms of early heart failure. How do we manage endocardial cushion defect? First, we need to address the congestive heart failure with the meds, diuretics, ACE inhibitors, if needed, positive inotropes, and then early surgical management. What do you expect to see in the ECG of endocardial cushion defect? We will have evidence of four-chamber enlargement in both ECG and chest X-ray. Well, then we have ventricular septal defect. We don't forget APERT as opposed to Hort-Ollem, which was the risk factor for ASD. APERT is the risk factor for VSD. We also don't forget Cri-du-Chat, Toches, and all trisomies. We also remember that the holosystolic murmur of VSD in lower left sternal border is defined as harsh. We also remember that the mid-diastolic rumble of VSD is in the apical area as opposed to the diastolic rumble of ASD, which was in the tricuspid region. Treatment is based on presence or absence of severe symptoms and moderate symptoms or mild symptoms. For mild symptoms, that's all patients, we use diuretics with follow-up echo. For moderate symptom, that is failure to thrive, we need providing nutritional support. And when there is congestive heart failure, pulmonary hypertension, and failure of medical management or any type of respiratory distress, we need to manage surgically as soon as possible. Important point about patent ductus arteriosus is not only machine murmur at the pulmonic or subclavicular area, but the management that needs to be divided into term versus preterm, presence or absence of contraindications to treatment or contraindications to medical management with endomedicine, such as bleeding diathesis, and indications to surgery. And finally, we remember the antibiotic prophylaxis is indicated in PDA if they have cyanotic congenital heart disease or have surgical repair of their PDA, as opposed to no need for antibiotic treatment for septal defect. And this is acyanotic congenital heart diseases.